You know, when we think about crime, our minds usually jump to, I don't know, street corners, maybe a bank heist movie.
Right, something dramatic, something you can see.
Exactly. But some of the biggest, most complicated theft doesn't happen with a weapon. It happens on paper.
Or, more likely these days, on a digital screen. Inside medical offices, insurance companies, billing departments.
And there is a specific kind of nightmare that keeps compliance officers, hospital administrators, and, frankly, anyone in the medical business awake at night.
It's not a malpractice suit. Not necessarily.
No, not even a bad patient outcome, though that's related. It's a letter.
A certified letter.
A letter with a state seal on it that references a very specific, very dense block of text. We were talking about Texas Penal Code, Chapter 35A.
Healthcare fraud. And I'm really glad we're doing this deep dive because I think a lot of people in the industry, even the ones who think they know the rules, they treat Chapter 35A like it's just another billing regulation.
Right. Oh, I messed up a code, I'll pay a fine.
Exactly. It's the cost of doing business. And that is a dangerous, dangerous assumption.
It sounds like a fatal assumption from a business perspective.
It can be. Chapter 35A is the legal line between writing a refund check and going to state prison. It is the weaponization of the penal code against the healthcare machinery.
That's a strong way to put it. Weaponization.
It is. Because this isn't just about a doctor charging a little too much. The law covers this massive, intricate web of providers, agents, and managed care organizations. What we're doing today is really looking at the machinery of how the state protects its healthcare money.
Okay, before we unlock the vault on this one and really start dissecting this weapon, I have a very specific and very important request for you listening right now.
Please do.
We spend hours, and I mean hours, combing through these dense legal stacks so you don't have to. If you're getting value from these deep dives, if you're enjoying this, please, right now, just pause for a second and hit that subscribe button.
It really does help.
It helps the show grow, it helps us keep the lights on, and most importantly, it makes sure you never miss one of these breakdowns. And hey, while you're at it, check out the website. You can see the actual text of the sources we're talking about today.
Absolutely. Support independent analysis. If you are in this industry, trust me, you are going to want to see the text we're referencing. It's one thing to hear it, another to see it in black and white.
All right, mission brief for today. The goal is translation. We have this dense, honestly terrifying block of legal text. Our job is to turn it into plain, simple English.
The mission is to understand exactly what constitutes healthcare fraud, how the law defines all the players involved, and the very severe consequences for breaking these rules.
And you mentioned setting the stage. When people hear healthcare fraud, what's the first image that comes to mind for them?
It's almost always a rogue doctor, billing for an extra checkup, charging for a service they didn't perform. And sure, that's definitely part of it, a big part of it.
But not the whole picture.
Not even close. Chapter 35A is looking at a much, much bigger web. It's looking at the entire ecosystem, the whole food chain of healthcare.
So let's start unpacking this. The outline here says Section 1 is all about the cast of characters. This is all defined under Section 35A.01. And I love this because, normally when you get a contract or some legal document, you just skip the definition section, right? You just scroll past it.
Everybody does. You want to get to the what I can and can't do part.
Exactly. But you're saying here, you absolutely cannot do that.
Here, the definitions are the what you can and can't do part. They define the battlefield. If you don't know who the law considers a player in the game, you can't possibly understand the crime.
Okay, so let's start with the biggest one, the central figure.
The provider.
The provider. Now, colloquially, in everyday use, you hear provider and you think, what?
Doctor, nurse practitioner, maybe a dentist. The person with the stethoscope touching the patient. Exactly, the person in the room. But the statute, it goes way, way wider than that. Section 35A.01, subsection 8, defines a provider as, and I'm paraphrasing a bit, a person who participates in or has even just applied to participate in a healthcare program as a supplier of a service or a product.
Okay, a supplier of a product. That phrase right there already opens the door a bit.
It kicks the door clean off the hinges. The code then explicitly lists things that you would just not expect. It includes a management company that manages or operates another provider.
Whoa. Okay, pause on that for a second. A management company. We see this structure constantly now in medicine. Big private equity firm comes in, they buy a dermatology practice or a chain of dental offices. The doctors are technically the medical providers, but the PE firm is in the back office handling strategy, billing, everything.
Yep.
Are you saying that PE firm is a provider under this law?
That is exactly what I'm saying. If that management company manages, operates, or controls the actual medical provider, they fall squarely under the definition. They can't hide behind the corporate veil and say, well, we aren't doctors, we're just business guys.
So that defense is gone.
The statute pulls them right inside the definition. It pierces that corporate veil for them.
So if the business guys at the top implement a new corporate policy that says, hey, from now on, bill for everything twice and see what sticks, they are just as liable under these healthcare fraud statutes as the doctor who actually signs the claim form.
They are providers under the law, period. Full stop. And it goes even deeper, getting into the real nitty-gritty of the logistics. Paragraph E of that same definition includes a manufacturer or distributor of a product for which a healthcare program provides reimbursement.
Whoa. Okay. Let's play a scenario with that one.
All right.
I run a small trucking company. I don't do medicine. I don't know a scalpel from a stethoscope. All I do is drive oxygen tanks from a warehouse to a nursing home.
Okay.
Am I a provider under Chapter 35A?
If that product, the oxygen in those tanks, is reimbursed by a healthcare program like Medicaid or Medicare, and you are the distributor, then yes, you are in the game. You are a provider as far as the law is concerned.
That is a massive, massive net.
It is.
It means the law can touch almost anyone in the logistics and supply chain of healthcare, not just the person performing the surgery or writing the prescription.
Precisely. It's designed to eliminate the I'm just the delivery guy defense if you are knowingly participating in a fraudulent scheme. If you know you're delivering watered-down drugs or faulty equipment, you can't just say, hey, I just drive the truck.
Unbelievable. Okay, there's another term in this cast of characters that sounds like a really boring office job, but you've flagged it as critical. The fiscal agent.
The fiscal agent? Yeah, it sounds like an accountant, but think of them more like gatekeepers.
Gatekeepers to the money.
To the public money.
Mm.
Section 35A.01, subsection 2, says a fiscal agent is a person who, through a contractual relationship with the state agency or the federal government, is in charge of receiving, processing, and paying a claim.
So they're the middleman.
The ultimate middleman. The state doesn't usually write a check directly to the doctor for every single patient visit. That would be an administrative nightmare.
Of course.
So they hire these huge entities, often big insurance companies or specialized processing firms, to handle all that paperwork. The fiscal agent is the entity standing right between the giant vault of public money and the thousands of hands reaching out for it.
Okay, so why does the law even bother defining them? Why not just have a simple rule that says, don't steal from the government?
Because of legal loopholes. Technically, when a doctor submits a claim, they aren't sending the bill to an office in the state capital. They're sending it to, say, Blue Cross, who might be acting as a fiscal agent for a state Medicaid program.
I see.
So a clever defense attorney might try to argue, Your Honor, my client didn't lie to the state of Texas. He lied to a private company called Blue Cross.
And Chapter 35A shuts that whole argument down before it can even start.
Hard. It slams the door. It essentially says, the fiscal agent is the state for the purposes of this law. Lying to the gatekeeper is exactly the same as lying to the king. They are a crucial piece of the puzzle because defrauding them is legally identical to defrauding the government.
Got it. Okay. So we have the people, the entities. Let's talk about the action itself, the claim. Now, this seems simple on its face. A claim is a bill, right? I did X, now pay me Y.
You would think so, and mostly you'd be right. But if you look at the definition in Section 35A.01, subsection 1, there is a crucial nuance here that really defines the entire concept of fraud in this chapter.
Okay, what is it?
A claim is a written or electronically submitted request that identifies a service or product as being reimbursable under a program.
Okay, sounds standard so far.
But listen to the qualifier that comes right after it.
Without regard to whether the money that is requested or demanded is paid. Ugh. Okay, that's big. So, let's say I'm a shady provider. I submit a completely fake bill for $1 million. The fiscal agent, the gatekeeper, looks at it, immediately realizes it's fake, maybe laughs out loud, and throws it in the virtual trash can. No money ever leaves the vault.
Right.
I still committed the act.
You still made a claim under the law. The crime isn't necessarily in the successful theft of the money. The crime is in the attempt to get the money. The definitions lock that concept in right from the very beginning.
So whether the check clears or not, you've already pulled the trigger on the statute.
That's the perfect analogy. It is a huge distinction. You cannot use, well, nobody got hurt because you were smart and didn't pay me as a defense.
Like the law is punishing the intent.
Precisely. It's like shooting at someone and missing. You don't get to just walk away because you have bad aim. You tried to defraud the system. The fact that the system's defenses worked doesn't absolve you of the crime.
And looking at the notes here, the definition of claim is even broader than that. It also covers statements about what income or expenses that are used to determine payment rates.
Yes, this is a big one for the institutions. Hospitals, nursing homes, large provider groups. They often have to submit what are called cost reports to establish their reimbursement rates for the coming year.
So they're not billing for a patient, they're billing for their overhead.
In a way, yes. They're establishing the basis for future billing. If a hospital lies on its cost report, let's say it claims its electricity costs were double what they actually were in order to get a higher reimbursement rate from Medicaid for every patient they see next year.
That submission, that cost report, is a fraudulent claim.
Yes. Even though it wasn't a bill for a specific patient for a specific surgery, it was a lie designed to get more money from the system.
That is sneaky. Very comprehensive. Okay, next character on our list, the healthcare recipient. This has to be the patient, right?
Yes, this is the patient. Defined in Section 35A.01, subsection 5. But again, just like with everything else in this chapter, there's a trapdoor built into the definition to prevent loopholes.
Of course there is.
A recipient is an individual to whom a service is provided, or even just purported to be provided, but then it adds this little phrase, without regard to whether the individual was eligible for benefits.
Meaning what, exactly?
Meaning, if you, the provider, try to bill Medicaid for a service you supposedly gave me, you can't later argue in court, well, it's not fraud because it turns out that guy wasn't even eligible for Medicaid anyway, so the state never would have paid the claim.
I see. So you can't use the patient's own ineligibility as a shield to protect you from your own fraudulent intent.
Exactly. It doesn't matter if they were eligible or not. If you use their name and their information to try and get paid, they are the recipient in the eyes of the law, and you are on the hook.
It really feels like this entire chapter was written by a team of prosecutors who are just very, very tired of hearing creative defense attorneys find these tiny technical loopholes.
That is exactly what this is. They just went through and systematically closed every single exit. It is a legally sealed room.
And speaking of sealed rooms and who's in charge, there's one more character we have to introduce before we get to the crimes. You called this one the boss-level character.
The high managerial agent.
High managerial agent. It sounds so formal, like something from a video game.
It does, but it's a very, very dangerous label to have attached to your name in a courtroom. This is defined in Section 35A.01, subsection 10.
So what makes someone a high managerial agent?
It's defined as a director, an officer, or an employee who is authorized to act on behalf of a provider. But, and this is the key, it's someone who has duties of such responsibility that the conduct reasonably may be assumed to represent the policy or intent of the provider.
Okay, so this isn't just the manager of the afternoon shift. We're not talking about a middle manager. We're talking about the people who are actually steering the ship.
Correct. This is the C-suite, the board of directors, the regional vice president, the people whose decisions set the culture and the policy for the entire organization. If you are high enough up the food chain that your actions are the company's actions, then you are a high managerial agent.
And we're going to get to this later in the penalties section, but I'm guessing that being in this category puts a massive target on your back when it comes to punishment.
It puts a multiplier on your punishment. It absolutely does.
All right, so we have our cast. We have the provider, which is basically everyone from doctors to truck drivers to private equity firms. We have the fiscal agent, who is the money gatekeeper, the recipient, the patient, and the high managerial agent, the boss.
Now, let's get into the crime itself, the playbook.
Section 35A.02, subsection A, the offenses.
This section reads like a how-to guide for going to prison. There are 20 different ways listed here to break the law, but as I was reading through them, I noticed a pattern. Almost every single one starts with the exact same word.
Knowingly.
Knowingly. Right. Why is that one word doing so much heavy lifting here? It's the safety valve. It's the difference between a crime and a mistake. I mean, think about it. Healthcare billing is incredibly, ridiculously complex.
Oh, yeah. The codes alone are a nightmare.
There are thousands upon thousands of ICD-10 codes. People make typos. Computers glitch. New employees who are poorly trained mess up. If you accidentally bill for a code 99214 visit when you really meant to bill for a 99213, that's an error. It's an overpayment. You discover it, you pay it back. It's not a crime.
So the state has to prove your state of mind. They have to prove intent.
To violate Chapter 35A, the state has to prove you did it knowingly. You knew the claim was false and you submitted it anyway. Or, in some cases, you are so willfully blind or reckless about the truth that it amounts to knowing.
So honest mistakes are safe. But if you know you're doing wrong, watch out.
That's the ball game.
Let's try to break these dozen offenses down into some logical categories, because there's a lot here.
Right.
Let's call the first one Category A, the lies.
Okay, that works. This would cover subsections 1 and 2. This is the bread and butter of healthcare fraud. Subsection 1 is knowingly making a false statement of material fact in a claim in order to get a payment that isn't authorized, or, and this is extremely common, a payment that is higher than authorized.
This is what the industry calls upcoding. Right?
That's the classic example of it. Exactly. Let's dummy this down. You go to the doctor because you have a simple sore throat. He looks in your mouth for 30 seconds, says, yep, it's red, take some lozenges, and sends you home. That is a basic level 1 office visit.
Okay.
But on the claim form he submits to the insurance company, he writes that he performed a complex evaluation with moderate to high-level medical decision-making.
He's telling the fiscal agent that he did way more work and more complicated work than he actually did.
Right. That is a false statement of a material fact. He's trying to steal the difference in payment between the cheap, simple visit and the expensive, complex visit. That's upcoding.
And subsection 2 is sort of the flip side of that coin.
It is. Subsection 2 is about concealment. Knowingly concealing or simply failing to disclose information that would have prevented a payment or reduced the amount of the payment.
So it's not just lying, it's lying by omission.
Precisely. Let's use an example. Let's say you know that a patient has private insurance, Aetna, Cigna, whatever. That should be the primary payer for their visit.
Okay.
But you also know that Medicaid sometimes pays faster or is just easier to deal with, and you'd rather get your money from them. So you deliberately hide the fact that the patient has private insurance, and you bill Medicaid as if they are the primary and only payer.
You concealed a crucial piece of information that would have reduced or even eliminated the state's payment.
Boom. Fraud. You had a duty to disclose, and you didn't.
There's also another specific type of lie mentioned here in subsection 4 that has to do with the facility itself.
Yes, this one is really interesting. It makes it a crime to lie about the conditions or operation of a facility in order to get that facility certified or recertified to participate in a healthcare program.
Oh, wow. So this isn't about a patient bill at all. If I'm running a nursing home, for example, and I lie to the state inspectors about how many fire sprinklers we have, or I fudge the staffing records to make it look like we have more nurses on duty than we do.
Just to pass the inspection and keep your license to operate.
That's healthcare fraud.
It is, because your certification is what allows you to bill the program in the first place. If you lied to get that certification, then every single bill you send from that day forward is fruit of the poisonous tree. You obtain the privilege of billing through a fraudulent act.
That makes perfect sense. It connects the regulatory compliance side of things directly to the financial billing side.
Yeah.
Okay, let's move to Category B. This is the stuff of spy novels. The kickback.
Subsection 5. This is a big one, and it's aggressively prosecuted. It says you cannot knowingly pay, charge, solicit, or accept any consideration as a condition to provide a service.
And consideration is just lawyer speak for stuff, right?
Any stuff of value. Money, gifts, donations, fancy dinners, all expenses paid vacations, sham consulting contracts, below-market office leases, anything of value.
So give me the simple, real-world explanation. How does this actually play out?
Okay, simplest version. I run a laboratory that does blood testing. You're a family doctor with a lot of patients who need blood tests.
All right.
I come to you and I say, hey, doc, if you agree to send all of your patients' blood work to my lab instead of the one across the street, I will send you and your entire family to Hawaii for 2 weeks, 5-star resort, everything's on me.
Sounds like a great vacation.
It's a felony. That vacation is a consideration that was given as a condition for you to provide a service referring patients that is paid for by a healthcare program. The law wants medical decisions to be based on what's best for the patient, not on who is buying the doctor a pina colada.
What if it's more subtle than that? What if I'm the lab owner and I say, Doctor, I'd like to pay you $5,000 a month to be a medical director for my lab, but then I never actually require you to do any real work. You just have the title.
That is a classic sham medical directorship. If the payment isn't for fair market value for actual legitimate services you're providing, and it's really just a way to buy your referrals, it's a kickback. It's fraud.
And the law cuts both ways. The guy offering the bribe and the guy taking the bribe.
The language is solicits, accepts, or receives. It also says offers or pays. So both sides of that handshake are getting handcuffed.
Brutal. Okay, Category C is what you've called the ghost and the imposter. This is all about licensing.
Right. This is mainly subsections 6 and 8. This whole category is about protecting the integrity of the profession and ensuring patients are treated by qualified people. Subsection 6 makes it a crime to present a claim for a service that was rendered by someone who isn't licensed to perform it.
So to use a ridiculous example, I can't have my landscaper perform a root canal on a patient and then bill Medicaid for it.
I would hope not, for many reasons. But yes, legally, no, you cannot do that. If a license is required to perform a service in Texas, the person doing the work must have that license.
But it also covers misrepresentation. Right. Claiming a service was done by a licensed professional when it actually wasn't.
Yes. This is where it gets more common. A classic scenario is in a therapy setting. Maybe the licensed therapist is supposed to supervise an unlicensed aide. But in reality, the aide does everything, and they bill it under the therapist's name and license number as if the therapist did it.
That happens, right. The doctor is supervising a nurse practitioner, but the doctor is on the golf course. The nurse does everything, and they bill it at the doctor's higher rate.
That can be a very dangerous gray area, and if you claim the doctor was the one providing the service face-to-face when they weren't, that is fraud. In fact, subsection 8 gets very, very specific about this. It makes it a crime to knowingly fail to indicate the type of license and the identification number of the licensed healthcare practitioner who actually provided the service.
The emphasis there is on the word actually. You can't hide who is really doing the work.
Yeah. Transparency is the weapon against fraud here. The law demands to know who was in the room. If a physical therapist assistant did the work, the bill needs to say that because they get reimbursed at a lower rate than a full physical therapist. If you hide the assistant's identity to get the therapist's higher rate, you are stealing.
Okay, this next category is the one that, honestly, it scares me the most, just as a potential patient. Category D, bad medicine.
This is where the statute makes a significant shift. It moves from just protecting the state's wallet to actively protecting the people of Texas. This is subsection 7. This is the part of the law that equates bad medical care with theft.
Walk us through that. How is providing bad medicine considered fraud? I always thought of that as a malpractice issue, a civil lawsuit.
It can be both. But look at the language in subsection 7, paragraph B. It is a crime under Chapter 35A to bill for a service or a product that is substantially inadequate or inappropriate when compared to generally recognized standards.
Substantially inadequate.
Yeah.
Just think about what that implies.
It implies that if I am a surgeon and I perform a surgery on you, but I do a completely butchered job, I rush it, I skip critical steps, I use non-sterile equipment, and then I turn around and I bill the state for a knee surgery.
The state's argument is that you didn't actually provide the service you billed for.
Exactly. You billed for a knee surgery. What you provided was a butchery. Therefore, the billing is a lie. You are essentially saying to the state, pay me for providing health care, when in fact you provided harm. You didn't provide health care.
That is a profound legal concept. It effectively says you are only entitled to the money if the quality of the care you provide meets a certain minimum standard.
It commodifies the quality. If the product, in this case the healthcare service, is defective, then the bill for that product is fraudulent.
And it also mentions dangerous goods.
Yes. Subsection 7, paragraph C. It's a crime to bill for a product that has been adulterated, debased, mislabeled, or that is otherwise inappropriate.
So, like giving a patient expired medicine and billing for the full price, in-date version.
That's a perfect example. Or the stuff of true nightmares, the diluted chemo scenario. A pharmacist who is watering down life-saving cancer drugs to stretch the supply further and increase profits while billing the state for full, unadulterated doses.
Which has actually happened.
It has happened. And under Chapter 35A, that isn't just an FDA violation or a pharmacy board issue, it's theft. You are stealing from the state by providing what amounts to poison instead of medicine. The law stops seeing a doctor or a pharmacist and starts seeing a scam artist selling counterfeit goods.
Wow. It really reframes the whole issue. It's not just financial. It's deeply physical and personal. Okay, last category of offenses, Category E. This is for the big organizations, the MCOs.
The managed care organizations, this is subsection 10, these are the massive entities, usually insurance companies, that have contracts with the Texas Health and Human Services Commission to manage the care for thousands, sometimes millions of people on Medicaid.
And they get their own special set of rules to follow.
They do, because they sit on an immense amount of public money and they wield a lot of power over patients' lives. The law makes it a specific crime if an MCO fails to provide to an individual a health care benefit or service that the organization is required to provide under its contract.
So taking the government's money, but then withholding the care.
That's the simplest way to put it. Managed care is supposed to be about managing care efficiently, not about systematic denial of service to boost profits. If they take the state's capitation payment, that's the lump sum they get per patient per month, but then they have an internal unwritten policy to deny required benefits to a certain percentage of patients, that is fraud.
So if an MCO has a secret internal policy of deny every MRI request on the first try no matter what, just to save money, hoping the patient gives up.
That could very easily be construed as fraud under this section. They are being paid to provide a benefit, and they are systematically failing to do so.
It also mentions falsifying info.
Yes. It's also a crime for them to falsify information they are required to report to the state or, and this is a big one, engaging in fraudulent activity related to the enrollment of individuals or the marketing of their services.
Like signing people up for their plan who didn't ask to be signed up.
Or targeting vulnerable populations with deceptive marketing practices to get them to enroll. MCOs are powerful, but Section 35A.002, subsection 10, is designed to put them on a very tight leash.
So that covers the main offenses. But the law doesn't just stop at the act of doing the fraud. It also covers what happens when the heat starts coming around. Section 3 in our outline covers obstruction and conspiracy.
Right. You can't talk about organized crime, and let's be clear, large-scale healthcare fraud is often organized crime without talking about the cover-up. Subsection 11 makes it a specific, separate offense to knowingly obstruct an investigation by the Attorney General.
So if the AG's Medicaid Fraud Control Unit comes knocking on your door with a subpoena and you suddenly start shredding documents or wiping hard drives,
that's a new crime. You just added a felony to your problem, separate from the fraud itself. And then there's subsection 9, which covers conspiracy. It's a crime to knowingly enter into an agreement to defraud the state.
this is how they catch the whole ring, not just the person who pushes the submit button on the claim. If I agree with you and 2 other people to run a scam, even if I don't personally file a single fake claim, I'm still in the conspiracy.
Correct. If you are in the room planning it, if you agree to participate, you are liable. And finally, there's a nasty little provision in subsection 3 about misuse of funds. This is knowingly applying for a benefit on behalf of another person, like a patient, and then converting that money to your own use instead of for the patient's benefit.
Converting, that is such a polite clinical way of saying stealing.
It is. It's getting a payment that's meant for a patient's in-home health care and using it to buy yourself a boat instead.
Okay. So we now know all the players, and we know the entire playbook of crimes they can commit. Now we have to talk about the consequences, the price. Section 4, the price you pay.
This is section 35A.02, subsection B, the penalties.
And this works like a ladder, right? A sliding scale.
A sliding scale, exactly. It is based almost entirely on the value of the fraud. The more money involved, the higher up the ladder of penalties you climb.
Let's dummy this down for everyone. Walk us up that ladder. Start at the very bottom rung.
Okay, bottom row, small change. If the total value of the fraud is less than $100, it's a Class C misdemeanor.
That's like a traffic ticket, a fine.
Basically. But as soon as you cross that $100 threshold, you jump to a Class B misdemeanor. That covers everything from $100 up to $750.
Okay, still misdemeanor territory.
Then from $750 up to just under $2,500, you're looking at a Class A misdemeanor. Now you're getting into potential jail time territory up to a year in the county jail, plus a hefty fine.
But the real pain, the life-changing stuff, starts when you cross that $2,500 line.
That is the felony threshold. From $2,500 to just under $30,000, it is a state jail felony. The moment you hit that, you are a convicted felon. You lose your right to vote, your right to own a firearm, and you are looking at time in a state jail facility.
And there's a special catch here for the obstruction charge we talked about earlier, right?
Yes. Remember that offense of obstructing an investigation? shredding the documents,
Uh-huh.
that is automatically a state jail felony, regardless of the dollar amount of the underlying fraud. Even if the fraud was only $50, if you obstruct the investigation into it, you've just bought yourself a felony.
And what if they can't figure out how much was stolen?
Also a state jail felony. If the court determines that the exact dollar amount of the fraud can't be figured out, it defaults to a state jail felony.
So if your books are so cooked and so messy that nobody can tell exactly how much you stole, you don't get off free.
No, you get a felony for your trouble.
Okay, next step up the ladder.
Now we're getting serious. From $30,000 to just under $150,000. That is a third-degree felony that carries a punishment of 2 to 10 years in a state prison.
That's serious prison time. But I see a note here that there's another way to get to that level, even without hitting the $30,000 mark, the frequent flyer rule.
The frequent flyer rule. I like that, yes. Section 35A.02, subsection B, paragraph 5, subparagraph B. It is also a third-degree felony if the defendant submitted more than 25 but fewer than 50 fraudulent claims.
Wait a minute, let's do the math on that. If I submit 30 separate fake claims for, say, $10 each, that's only $300 total. Based on the dollar amount, that should just be a Class B misdemeanor.
But because it was 30 separate criminal acts,
It automatically gets bumped up to a third-degree felony.
correct. The law is designed to punish the habit and the system of fraud just as much as the total dollar amount. If you are churning out a high volume of fake claims, even if they're for small amounts, the system hammers you. It's specifically trying to catch automated systemic fraud.
That is wild. 30 tiny lies can equal a 10-year prison sentence. Okay, next rung up.
Second-degree felony. This is for fraud valued at $150,000 to just under $300,000. Or
Frequent flyer rule part 2.
Or if you submitted 50 or more fraudulent claims. Again, regardless of the dollar amount of each claim, the moment you hit your 50th fake bill, you are in second-degree felony territory. That carries a potential sentence of up to 20 years in prison.
And the top of the mountain. The absolute max.
First-degree felony. That kicks in if the value of the fraud is $300,000 or more. That's a punishment of 5 to 99 years or life in prison.
$300,000.
Yeah.
It sounds like a lot of money to a normal person. But in the world of healthcare, with expensive surgeries, pharmaceuticals, MRIs, that can add up terrifyingly fast.
It adds up incredibly fast. A single fraudulent scheme involving a handful of patients over a year could easily cross that threshold. And that leads us to what is probably the most dangerous weapon the prosecutor has in their arsenal under this statute: aggregation.
Aggregation. This is in section 35A.02, subsection D. You call this the stacking rule.
The stacking rule. You see, a good defense lawyer is always going to try to break the crime down into its smallest possible parts. They want to argue, Your Honor, my client didn't commit one big felony theft of $300,000. No. He committed a tiny $100 misdemeanor theft. And then the next day he did it again, and the next. These are just a series of little unrelated misdemeanors.
These are all separate incidents, Judge.
And the law, subsection D, says absolutely not. It says, and I'm paraphrasing, when multiple payments are provided as a result of one scheme or continuing course of conduct, the conduct may be considered as one offense and the amounts aggregated. So
they get to add it all up into one giant, terrifying lump sum.
They stack every single penny from the entire scheme together. If you stole $100 1,000 times as part of the same plan, you are not facing 1,000 misdemeanor tickets. You are facing one first-degree felony charge for a $100,000 theft.
Wow. That completely changes the risk calculus for any potential criminal. You can't just nickel and dime the system to death because the system does the math at the end.
Correct. It's designed specifically to prevent that death by 1,000 cuts strategy of fraud.
Okay, now let's circle back to that boss-level character we talked about at the beginning, the high managerial agent.
Oh, yes. The boss.
Let's talk about Section 5 in our notes, the corporate hammer. This is Section 35A.02, subsection E. What happens if you are the boss and you get caught doing this?
This is what I call the escalator clause. The law says that if the state can prove beyond a reasonable doubt that the person who committed the offense was a high managerial agent at the time of the offense, the punishment for that offense is increased to the next highest category.
Ouch. So, give me an example. If I'm the CEO of a hospital and I direct a scheme that nets $100,000 in fraudulent payments, that's normally a third-degree felony.
But because you're the CEO, a high managerial agent,
it automatically becomes a second-degree felony. My potential prison time just doubled.
That's right. And if you commit a second-degree amount of fraud, say $200,000,
it becomes a first-degree felony with a potential life sentence.
It does.
Why? Why punish the boss harder for the same amount of money stolen? It seems like the crime is the same.
Because the law recognizes that culture starts at the top. If the director of the company or the owner of the clinic is engaging in fraud, they aren't just stealing money. They are corrupting the entire organization from the top down. They are leveraging their position of power and trust to facilitate a crime. They are ordering their subordinates to break the law, putting them at risk.
So the law demands a higher standard of conduct from the people in charge.
It punishes the abuse of power, not just the underlying theft. The person at the top has a greater responsibility, and therefore they face a greater penalty when they violate that trust.
That makes total sense. You're not just a thief, you're a corrupt leader. What's the exception?
The only exception is if the crime is already a first-degree felony based on the dollar amount. You can't go any higher than first degree.
Fair enough. You can't get a super-duper first-degree felony.
Not yet, anyway. Don't give him any ideas.
Okay, last major section here, Section 6. Who is coming to get you? Jurisdiction and prosecution.
This is covered in Section 35A.02, subsection F. And it's interesting because normally local crimes are prosecuted by the local county or district attorney.
Right.
But for healthcare fraud, the Texas Attorney General, the AG, has concurrent jurisdiction.
Meaning they can work together, the local DA and the state AG.
Yes. With the consent of the local prosecutor, the AG's office can step in and take over or assist with the prosecution. This is a huge deal because it allows the state to bring in highly specialized resources.
What do you mean?
Healthcare fraud is incredibly complex. To prove a case, you need forensic accountants, medical coding experts, data analysts who can sift through millions of lines of billing data. The local DA in a small rural county might not have those resources on staff, but the AG's Medicaid Fraud Control Unit does.
So it allows the state to bring the big guns to a fight, even if it's happening in the small town.
Exactly. It levels the playing field.
And what about this note on double trouble?
Ah, yes. Subsection C. This is basically the reverse of a double jeopardy clause. It explicitly states that if the criminal conduct breaks this law, A&D another law on the books, the state can prosecute the person under this section, the other section, or both.
So a defendant can't stand up in court and say, hey, you already charged me with theft under the general theft statute, so you can't also charge me with healthcare fraud for the same act.
The judge will just say, watch me. The code explicitly allows for prosecution under multiple provisions. You can face charges on every possible front for the same scheme.
Man, it really feels like the walls are closing in when you read this chapter.
Yeah.
It is designed from top to bottom to be inescapable.
That's the design. It is meant to be a powerful deterrent.
So let's try to wrap this up and put a bow on it. We've covered a ton of ground today.
We certainly have.
We established that providers aren't just doctors. They are vendors, managers, private equity firms, the entire supply chain. We learned that making a fraudulent claim is a crime in itself, even if you don't actually get paid.
We drilled down on that critical word, knowingly, which is what separates a simple billing error from a felony.
We looked at the whole playbook of offenses, the lies, like upcoding, the kickbacks, which is basically bribery, the ghosts and imposters using unlicensed staff, and the one that really hits home, the bad medicine.
And then we climbed the ladder of penalties. We saw how aggregation can turn hundreds of tiny misdemeanors into one massive felony, and how the high managerial agents, the bosses, get bumped up to the next grade of punishment just for being in charge.
It is an incredibly comprehensive, frankly, a very intimidating system. But what's the one thing that really stands out to you, having gone through all of this again, if you had to leave the listener with one big final thought?
You know, for me, it always comes back to that category called bad medicine. I think we often have this idea of white-collar crime as being victimless or just about money moving around on spreadsheets. People think, oh, it's just the government or some giant insurance company losing money. Who cares?
Right. It feels abstract. It doesn't feel like a robbery.
But Chapter 35A directly challenges that entire notion. It explicitly defines healthcare fraud, not just as stealing money, but as providing inadequate substandard care in order to maximize your profit. It says that if you treat a patient with shoddy tools or give them diluted medicine or perform a useless procedure just so you can bill a code, you are no longer a doctor in that moment. You are a thief.
That is a really powerful way to frame it.
It equates malpractice with larceny. It says the state is paying you for a service called health. If you fail to deliver health, if you deliver harm instead, you have no right to the money. It puts the patient's physical well-being right in the center of the financial transaction. And it reminds us all that at the end of every single one of these claim forms is a human being, a person waiting for care, hoping to get better.
That is a provocative thought to leave this on. The idea that in the eyes of the law, bad medicine isn't just negligence, it's a form of theft.
Precisely.
Well, on that note, I think we are going to close the book on Chapter 35A. Thank you for diving this deep with us today. It was illuminating.
It was my pleasure. Always is.
And to you listening, thank you for your time and your attention. If you want to read the fine print yourself, and believe me, there's always more in the fine print, check out the sources on our site. And please, don't forget to subscribe. Until next time, stay curious.
And stay legal.
See you next time.